Good afternoon, everyone. I am Dr. Ahmed D. Abdulwahab. I'm a radiologist at the Rizgary Teaching Hospital. Today, we will present a presentation about the radiological abnormalities of the fingers. I hope you will all join me and enjoy this presentation. Okay. So the radiology of bony pathologies of the fingers. First, we have to know that the primary bony tumors of the hands are rare. They are about 2 to 5% of all skeletal tumors, and the vast majority of them are benign tumors. And most of the times they are just an incidental finding. When we find any bony lesion, we have to use the systematic approach of the bony tumors that we should use anywhere all over the body, including the evaluation of the size, the number, and the location of the lesions, the margins, and the zone of transition, and the presence of any periosteal reaction or matrix mineralization, and the presence of a soft tissue component. So regarding this approach, we will talk briefly about each component. First of all, as with any bony lesion, the location of the tumor and the age of the patient is of very important in narrowing the differential diagnosis. The margins of the lesion and the zone of transition between the lesion and the adjacent bone is very important to determine the aggressiveness of the lesion because malignant lesions usually have, the margins are different from those of benign lesions. The lesion, if it's a well-defined, sharp margin, usually it is a non-aggressive lesion, while if the zone of transition is broad, the borders are poorly defined, it indicates an infiltrative osseous process like an aggressive tumor or destructive metabolic or infectious process. So the aggressive lesion means primarily either malignant or infectious, okay? The presence of periosteal reaction also should be evaluated. If the periosteal reaction has a smooth outline with solid appearing periosteal reaction, this indicates a slow non-aggressive process, while if it is disrupted, irregular, or sunburst appearance, this indicates aggressive lesion. The mineralization and the opacity of the lesion, it determines the origin of the lesion, which component of the bone is forming this tumor. If we identify the bony matrix or the matrix of the lesion to show a calcification in the form of rings and arcs, this indicates a chondral origin, like enchondroma or chondrosarcoma, while if it is opaque and the cloud-like matrix indicates osseous mineralization. Lytic lesions that are not showing any kind of calcification, this indicates a wide variety of differential diagnosis, and the differential diagnosis of lytic lesions can be remembered by remembering this mnemonic, Fogg's machine. Fogg's machine will be as the following. Fogg, the F is for fibrous dysplasia, then osteoblastoma, giant cell tumor, simple bone cyst, metastasis or myeloma, aneurysmal bone cyst, chondroblastoma or chondromyxoid fibroma, hyperparathyroidism, infection, non-ossifying fibroma, enchondroma, or eosinophilic granuloma. These are all can be presented in the form of lytic lesions, Fogg's machine. So let's start with the benign bony lesions of the fingers specifically. First of all, the most common one is the enchondroma. So the enchondroma, it's a benign cartilaginous tumor, and it's the most common benign tumor of the hand, usually asymptomatic, and sometimes can present with pain, and here we should look for any pathological fracture. It is usually presents as a well-marginated lucent lesion, and it arises from the medullary cavity of the bone near the physis, near the growth plate, and it may cause local bone expansion, thinning, and endosteal scalloping of the cortex, narrowing the cortex from the endosteum. The chondroid matrix has, as we said, cartilaginous origin, so it will present as rings and arcs appearance. Because it's cartilaginous, it will be hyperintense on T2 weighted images and typically demonstrates only the peripheral nodular and septal enhancement, just the periphery and some nodular septal enhancement. If any enchondroma is on follow-up presented with or developed newly severe pain or interval growth or loss of any of the marginal definition, cortical disruption, or local periosteal reaction, keep in mind it might be due to malignant degeneration. Although this is rare, but it can happen. So we should look for these changes. If they happen, then possibility of malignant degeneration should be considered. For example, you can see this X-ray here. There is a fracture at the proximal part of the phalanx, and you can see, if you look carefully, there is an hypodense lesion. It's a well-defined with a narrow zone of transition with some calcifications in the forms of rings and arcs, indicating that this is an enchondroma with pathological fracture. Another example here, you can see there is an enchondroma at the metacarpal bone, the fourth metacarpal bone, very well defined with endosteal scalloping and thinning, and it has the typical rings and arcs calcification. And this lesion was surgically treated with bony grafting, curettage and bony grafting, and you can see the follow-up images with very marked improvement and ossification of the bony graft. Another typical enchondroma here, you can see the lytic lesion with a narrow zone of transition and endosteal thinning and scalloping, but no destruction and no associated soft tissue component. Here there is no pathological fracture. After the presentation, we'll have a few minutes for any discussion, so keep any questions that you have for the end of the discussion. Now, let's look here. There is a thin pathological fracture with some periosteal reaction indicating a fracture that is starting to heal. It's a non-displaced fracture, and you can see the enchondroma within the metacarpal bone, and there is some causing pathological fracture with healing process. Now, let's look at this lesion. There is obviously a lytic lesion that is expansile with endosteal scalloping and expansion, bone expansion. However, there is no periosteal reaction, no soft tissue component, no bone destruction, and typical rings and arcs calcification, and this indicates an enchondroma. Now, what if the patient presents with multiple enchondroma? This is called enchondromatosis or Ollier's disease. It is a rare non-hereditary disorder. The mean age of the diagnosis is about 13 years, presents with multiple enchondromas in asymmetric distribution. Asymmetric. Frequently involves the bones of the hand, especially the small bones, and this will result in skeletal deformities. The metacarpals are more involved than the phalanges. Okay. Regarding multiple enchondromatosis or Ollier's disease, the malignant transformation can happen to chondrosarcoma with increased the risk when the enchondromas are located in the long bones and in the axial skeleton. There is more risk than when the lesion is in the small bones of the hand. And the mean age of diagnosis is 33 years. Multiple synchronous or metachronous chondrosarcomas can happen also in Ollier's disease. For example, this X-ray here, you can see there are multiple enchondromas in the metacarpals, in the phalanges, proximal and middle phalanges. Most of them don't show any evidence, I think all of them, doesn't show any evidence of malignant transformation. You can see the well-defined margins and the rings and arcs calcification. And you can see the bony deformities here and here. It's very obvious due to their multiplicity. Okay. Another example of enchondromatosis you can see here. This possibly, or this might need some further evaluation due to the interrupted overlying cortex. It might be due to malignant transformation. Also, it's in the metacarpals and in the phalanges, and it causes deformities and joint destruction. Now, another lesion that we might see in the hands, and it's almost very symmetric, very similar to enchondroma, is Periosteal Chondromas. They are also benign cartilaginous tumor with similarity to enchondromas, but the difference is that they arise from the periosteum, not from the medullary cavity, not from within the bone, from the periosteum. They are rare, frequently in the metaphysis of long bones. In the hands are rare in this regard. Surface lesions, they present as a lesion on the surface of the bone with erosion and sulcerization of the adjacent cortical bone, and they can be mistaken for chondrosarcoma. Now, let's see this example here. You can see there is a lesion that is periosteal in origin. It's from the periosteum. The underlying bone is probably slightly involved at the distal part, but it's mainly periosteal with some calcification in the form of rings and arcs, and it looks like an enchondroma, but it's not within the bone. It's within the periosteum, protruding into the soft tissue. And again, like enchondromas, you can see it is hypo on T1 and hyper on T2 weighted images, hyperintense on T2 weighted images. So this is a periosteal chondromas. Again, another example, you can see this lesion arising from the periphery, while the enchondroma should be central in location. Peripheral with chondroid calcification indicates periosteal chondroma. This is the lateral image, and this is another patient with a rather large chondroma of the periosteum. You can see the typical rings and arcs calcification with a sparing of the underlying bone, which is not involved, obviously. Now, regarding osteochondromas, osteochondromas are the most common benign bone tumors all over the body is the osteochondromas, or what's called exostosis, okay? They are composed of both cortical and medullary bone. So the same as the parent bone, the original bone, it has a cortical bone and medullary cavity with overlying hyaline cap. So the hyaline cap is the chondro part, and the cortical and medullary bone as the osteo part. So it's osteochondroma. The radiological continuity of the underlying bone cortex and medullary cavity is pathognomonic. When you see the medullary cavity and the cortical bone connected to the original bone, to the parent bone, this is pathognomonic for osteochondroma. It also can be incidental findings, or they might be symptomatic due to their location and size, can present with progressive painless deformity around the joint, also fracture, vascular compromise, neurological sequelae, bursa formation, and malignant degeneration. For example, let's see this case. You can see this case, it's causing deformity at the tip of the finger. Also here, it is an osteochondroma. Now, osteochondromas presents with two appearances, okay? Either sessile, which is a broad-based tumor, or pedunculated. The osseous continuity between the parent bone is very important to look for, especially, and it's more easier to be seen, especially in pedunculated lesions. Characteristically, it will point away from the nearest joint. So it's away from the joint. The direction is away or distal or farther from the the nearest joint. The subtle chondroid matrix or the hyaline cap can be, by radiologists, not by plain films, I mean, not very easily seen. It's better evaluated by CT scan, and the thickness of the cartilaginous cap can be measured easily, especially more easily in MRI imaging. In MR imaging, the osseous continuity between the exostosis and the parent bone is very easy to be appreciated. You can see the osseous part and the medullary part very easily at the MRI. Also can detect any local effect, for example, pressure effect on the tendons or neurovascular bundles, resulting in a high T2 signal along these structures. Also, it's, as we said, it's used to evaluate any the cartilage cap thickness, which is a very important to measure in cases where there is suspicion of malignant transformation. Keep in mind that osteochondromas, like the bone, they stop growing at skeletal maturity. When we reach skeletal maturity, they should stop growing. If they grow, this indicates possible malignant transformation to low-grade low-grade chondrosarcoma. The cartilage cap, we should measure it. Maximum accepted thickness is up to 2 centimeters. If it is more than 2 centimeter thickness, there is a high risk of malignant transformation. Also, other features that we should look for, including the interval growth in the indistinct cortical margin, any erosion of the lesion and the adjacent parent bone, and any soft tissue component. Okay, so we can see here, this is the osteochondroma in the hand that we talked about. This is another example. This is a sessile osteochondroma. Here, look for the continuity with the cortical bone of the original parent bone and the medullary cavity, and you can see here this causes this deformity, and by surgery it has a pearl appearance. It looks like a pearl. Another example, you can see this is an osteochondroma that's directed away from the nearest joint, okay, and it has a continuity with the parent bone, with the cortical and the medullary part. Now, like enchondromas, when they are multiple, it's called Oyer disease or enchondromatosis. Exostosis, when they are multiple, it's called hereditary multiple exostoses. It's familial in nature, familial osteochondromatosis, and presents with multiple osteochondromas, has an autosomal dominant inheritance. Men are 1.5 times more affected than women, and up to 30% of the affected patients have lesions in the small bones of the hand, okay? Osteochondromas typically are sessile, slightly increased propensity for malignant degeneration. I think my personal opinion is due to their increased number, so the probability will be more, and it will require periodic clinical and radiological follow-up to look for any progression of the deformity and any possible complications, especially malignant transformation. So this is a case of multiple hereditary exostoses or multiple hereditary osteochondromatosis. You can see there are multiple osteochondromas directed all away from the nearest joint. This is the nearest joint, which is the knee. It has continuation with the parent bone and the medullary cavity, and no signs of malignant degeneration. At least by plain film, we can't see any bone destruction or soft tissue component. Also, there is a lesion in the radius here, and there is a lesion here which causes shortening of the metacarpal. So, another pathology that we should know about is the subungual exostosis. This subungual exostosis, also known as the Dupuytren exostosis, it looks like exostosis, but histologically it's different from osteochondromas. Not histologically, it's different from the exostosis, the normal one or the common one. It has no continuity with the cortex, no continuity with the medullary canal of the adjacent bone, and it is thought to represent a sequelae of prior insult, like infection or trauma previously, resulting in formation of this lesion. It usually arises in the dorsal aspect of the distal phalanx, okay, under or adjacent to the nail bed. That's why it's called subungual. Subungual because it is this under or adjacent to the nail bed, presents as a painful mass adjacent or under the nail bed, with possible even skin ulceration can be happening. Pedunculated cyst can be pedunculated or sessile bone spur that in the distal phalanx extending to the nail bed. This is what we see radiologically. and may demonstrate a cartilaginous cap larger than the base of the lesion. So the cap, it's like mushroom shape. The cap is larger than the base, okay? So it looks like an exostosis, but it is histologically, it's not. The MR imaging will show you the effect on the surrounding structures and allow you to differentiate this lesion from an osteochondroma or the the conventional exostosis. Fibrocartilaginous cap, here it is hypointense on all MR sequences, while the cartilaginous cap of the conventional exostosis, it's hyperintense on T2, while in subungual exostosis, it is hypointense on all sequences. Recurrence rate after surgery, unfortunately, it's high. For example, you can see here at the distal aspect, distal pharynx on the dorsal aspect, at the level of the nail bed, under the nail bed, there is a lesion. It might be an exostosis. However, if you look at the MRI image, you can see this is an axial image. You can see this is the parent bone. There is no continuity with the parent bone. The underlying cortex is intact, and the cartilaginous cap is hypointense. So this is not a conventional exostosis. This is a subungual exostosis. Another example you can see here, it is a lesion at the dorsal aspect of the distal pharynx under the nail bed, and another example here also in the toe there is a lesion. So it's not only in the hand, can be in other places like the toes. Another condition also can affect the bones of the hands is what's called the florid reactive periostitis. Florid reactive periostitis. What's this florid reactive periostitis? It typically involves the small bones of both hands and feet in young adults, and most frequent in the index finger, followed by the middle and little fingers. These are the commonest sites. The predilection for the proximal pharynx is more, and it presents as, it says the name is periostitis, so there is some sort of inflammation. So it presents as a progressive painful inflammatory swelling of the finger with paraosseous mass, with calcifications. The periostitis resulting in periosteal reaction, which is either lamellar or compact. Close interval follow-up should show you that the periosteal reaction becomes maturation, without any bone destruction, so it should not be confused with, for example, Ewing sarcoma or other pathologies. Typically, there will be a radiolucent band present between the paraosseous mass and the cortex of the adjacent bone. So the mass separated from the cortex of the bone by a lucent band or line. For example, this is a case of florid reactive periostitis. You can see this is the periosteal reaction, and over time it will mature with a very thin line that separates it from the parent bone. Some sort of like myositis ossificans, for example. Do you look for this line to differentiate? It's not from the bone. Okay, and on MRI image, you can easily appreciate the surrounding edema due to the inflammation. Okay. Another example is this one. You can see it's a florid periosteal reaction resulting with inflammation causing soft tissue swelling, and the underlying bone is somewhat not very, there is no definite destruction of the underlying bone. You can see the cortex is intact bilaterally. It has a propensity for the proximal phalanx, and it's more commonly affecting the proximal finger, and also it's very common site for this florid periosteal reaction. Another example can be seen here. You can see the periosteal reaction with intact underlying bone and soft tissue swelling. Follow-up will show maturation of this soft tissue reaction. A rather interesting entity that we should keep in mind, it's what's called bizarre Parosteal Osteochondromatos proliferation. It's a long name, bizarre Parosteal Osteochondromatos proliferation. So if you don't want to remember all of that, just remember it's called Nora lesion. Nora lesion. I have no idea why it's called Nora lesion, but that's what's written in the literature. It has a bizarre histologic appearance. Benign exophytic surface lesion of the bone. It's a surface lesion from the surface of the bone, frequently affecting the small tubular bones of the hands and feet. it has a predilection for the proximal and the middle phalanges, more in these two parts, the proximal and the middle phalanges of the hand and feet, especially of the hand. The vast majority of these lesions of the hand are situated in the diaphysis and the metaphysis. So it's affect mainly the diaphysis or the metaphysis, the metaphysial. Less commonly in the metacarpals and arise from the periosteal aspect of intact cortex, like the periostitis. The cortex is intact from the periosteum without involving the medullary canal. Okay? Now, let's look at this example. You can see it's arising from the metaphysial metaphysis of the middle phalanx here and here and here. It's from the periosteum. It has no relation with the medullary cavity or the underlying bone. The cortex is intact. Okay, it's in the hand, which is a common location, and you can see by MRI it is. It has no connection with the underlying bony canal with intact cortex. It's just involving the soft tissue mainly. Now, where is the lesion here? You can see it is at near the metaphysis or near the head of the second metacarpal bone. It is periosteal in location, and it has no connection with the underlying bone. Of course, there is here probably some sort of fractures, could be incidental finding. This is the Nora's lesion. Another example, you can see the difference from the periostitis, the florid periostitis that we see previously. There is no thin linear hypodense band. If we see the band, then the possibility of florid periosteal is more likely. You can see here and here also, it's all arising from the periosteum and bulging into the surrounding or the adjacent soft tissue. Now, osteoid osteoma is a very famous lesion, infrequently presents in the small bones of the hands and feet. Typical history of pain during night relieved by aspirin. But the symptoms in the hand can be different. Can be some soft tissue swelling, nail deformity. If it is in the distal phalanx, the region in the distal phalanx manifests as a peripheral region of sclerosis with a nidus in the center, typical. And the CT, at the CT, the nidus is more easily seen. The nidus on the MRI will present as hyperintense lesion on T2 weighted image, peripheral hypointensity due to the sclerosis on the T1 and T2 weighted image. The MR imaging may provide additional details of any inflammatory abnormality or changes of the soft tissues, of the surrounding soft tissues. And use of gadolinium will make the nidus enhancing, and it will be more obvious. This is an osteoid osteoma at the proximal phalanx of the finger, and you can see the nidus in the center, some surrounding sclerosis with surrounding soft tissue swelling and inflammation. On the MRI, it's very obvious this is the nidus, and this is an edematous soft tissue, and you can see the sclerosis surrounding it on the adjacent cortex. Again, you look carefully here at the site of the pain first, and you look at the site of the swelling, okay? And then let's look very closely, and you can see very tiny nidus here with some surrounding sclerosis, and this is an osteoid osteoma of the proximal phalanx. You can see this very small, tiny, lucent lesion. Now, another example, you can see here, this is an osteoid osteoma here with surrounding sclerosis and soft tissue swelling. On the lateral images, you can see it here on the cortex with some sclerosis, okay? And on the CT scan, make it even more obvious as a lucent lesion with surrounding bony cortical sclerosis and thickening. Other lesions that we should consider is what's called the aneurysmal bone cyst, or we simply refer to as the ABC. So the aneurysmal bone cyst, it is a lesion which presents with multiple cavities filled with the blood, mostly in children and young adults. So it is before the closure of the epiphyseal plate. Can present with swelling, pain, usually in the metacarpal bones, expansile lucent lesion with cortical thinning. It has internal subtations and trabeculations resulting in a multi-loculated appearance. You can see here it's within the medullary cavity. It's expansile with bone thinning and multiple subtations resulting in a multi-loculated appearance. Again, you can see it here. This is an aneurysmal bone cyst, and this is another aneurysmal bone cyst with multiple septations and loculation. And it is before the epiphyseal, the skeletal maturation, the growth plate is not closed, and it does not involve the adjacent cortical or articular surface of the bone. Again, this is another aneurysmal bone cyst. You can see multiple loculation, expansion with cortical thinning, and this is another one that does not reach the articular surface of the bone. Here is the important part to look for any articular involvement, to differentiate it from a possible giant cell tumor, which presents as a lytic tumor that develop at the end of the bone after the epiphyseal closure. So it's an older age group, mostly benign, 20% are malignant in the hands. It has predilection for the metacarpal bones, presents as an osteolytic lesion that extends to the subarticular cortex. Can be locally aggressive, resulting in cortical disruption, periosteal reaction, soft tissue mass. Like you see here, some lytic lesion that involves the distal aspect of the distal phalanx with, there is no septations, no loculation, so it is, histopathology was a giant cell tumor. Another example here, you can see this lesion extending to the articular surface of the bone in a skeletally mature patient. You can see the growth plates are closed, indicating possibility of giant cell tumor. Another lesion is seen here, also involving the articular surface. Now, there are some mimics of primary osseous bony lesions like Glomus tumor. Glomus, it's a benign hematomatous tumor that presents with excruciating pain and temperature sensitivity. It can be seen anywhere in the body, but the vast majority are in the hands, especially at the fingertips. Can cause pressure erosion of the adjacent bone. It's hyperintense on T2, hypointense on T1 with marked post-contrast enhancement. You can see this lytic lesion at the distal phalanx at the fingertip that is hyperintense on T2 and hypointense on T1. Another Glomus tumor at the tip of the distal phalanx. You can see it here. Another example, you can see a lytic lesion here. Now, other mimic is what's called intraosseous epidermal inclusion cyst, which is also a benign lesion. Cystic in the hand can be found in the subungual location. Intraosseous epidermal cyst affects the phalanges of the hand and the feet. Presents also with pain and swelling of the fingertip. The X-ray will show an osteolysis, most commonly in the terminal phalanges of the fingers. On the MRI, it will have an intermediate signal on T1 and T2 weighted images with central debris and some peripheral post-contrast enhancement. It causes extensive inflammation of the surrounding soft tissue, may suggest rupture of this lesion if you see the inflammation of the surrounding tissues. So here you can see there is a lesion at the distal phalanx that's eroding the adjacent bone, and it looks like an aggressive lesion, but if you look at the MRI, you can see this is the parent bone, and this is the epidermal inclusion cyst with intermediate signal. Surrounding edema can be due to rupture of this inclusion cyst. Another example of an epidermal inclusion cyst at the tip of the bone, okay? And another example, you can see at the distal phalanges more, and its erosion causes some erosion of the bone. And another example here, okay? You can see the lytic lesion eroding the bone. Also, trauma, infection, and systemic diseases should be differentiated, like sarcoidosis, which presents with less like osteolysis. On the MRI, there will be cortical disruption, periosseous soft tissue extension with granulomatous nodules. Also, tophaceous gout can be seen in the hand. Hyperparathyroidism with formation of Brownie tumor, and rheumatoid arthritis also can affect the hands with juxta-articular changes and possible pressure erosion from overlying rheumatoid nodules. You can see here. This is a case of sarcoidosis with lace-like pattern, okay? And another case, two cases of a big tophaceous gout. You can see the tophi everywhere. So this is tophaceous gout. Rheumatoid arthritis can affect the joints and juxta-articular extension and some soft tissue swelling and deformities. Another example of rheumatoid arthritis, you can see obviously the deformities and the involvement of the small bones of the hand. Hyperparathyroidism with bony tumors also, we talked about it in the previous presentation, and you can see these are the bony tumors. Here you should look for other signs like the subperiosteal resorption on the radial aspect of the phalanges. Okay, these are typical, and the cortical tunneling and other findings of hyperparathyroidism. Trauma can unusually shape fracture with trauma can cause fractures that are of unusual shape and can be confused with osteochondromas. Infection also can cause local areas of lysis associated with periosteal reaction region of sclerosis, and radiographically some cortical breakthrough and soft tissue mass can be seen. Malignant tumors of the heart, the primary malignant tumors are rare, like chondrosarcoma, hemangioendotheliosarcoma, osteosarcoma, fibrosarcoma, and Ewing sarcoma reported in the hand. Chondrosarcomas are the most common primary malignant bone lesion of the hand, most frequently affecting the proximal phalanx, maybe de novo or from malignant transformation of benign cartilaginous lesions like enchondromas. They are difficult to distinguish from chondrosarcoma from the enchondroma, but we should look for changes like phalangeal chondrosarcomas are locally aggressive. Unlike chondrosarcoma of other skeletal structure, they rarely metastasize, they're just locally aggressive. Mixed lytic and sclerotic appearance of the affecting bone, with sclerosing lesion representing the chondroid matrix mineralization. If it is a higher grade lesion, can demonstrate less matrix mineralization. So no mineralization, it is a higher grade lesion. More aggressive pattern, bony lysis like moth-eaten or permeative appearance. Also cortical breakthrough, irregular cortical thickening, and soft tissue components are all suggestive of chondrosarcoma. You can see here, there is chondroid matrix with bone destruction and large soft tissue component. Other malignant tumors like squamous cell carcinoma and malignant melanoma also can infiltrate the soft tissue, can infiltrate the bone. Squamous cell carcinoma are the most common malignant tumor of the hand, of the nail unit, and the majority are found in the second and third digit, with involvement of the bone uncommonly occur. Metastatic lesions to the hands are extremely rare with poor prognosis. The distal phalanx is the most common site of involvement. The primary tumors include tumors of the lung, genitourinary, and the breast, like mostly it's squamous cell or renal cell carcinoma. Occasionally, metastasis to the finger can be the primary manifestation and can be confused with infection at the initial workup. You can see here, there are multiple metastatic lytic lesions involving all the bones of the hand, and we should look for the primary in this case, which was a squamous cell carcinoma. So in conclusion, the tumors and tumor-like lesions of the small tubular bones of the hand are exceedingly rare. The vast majority are benign lesions, and the changes in the radiographic appearance or development of persistent new symptom may indicate malignant transformation. A variety of systemic and local processes can mimic aggressive bony lesions of the hand. Multimodality approach is needed to characterize the lesion and assess any related complications. Thank you very much. Hope you get benefit from this presentation, and see you all in the next in the coming activities, inshallah. Thank you very much.